We'd like to move on to the last topics of this session. The last speaker is my co-chair, Dr. Bandhan Sutrong. He's going to discuss on how to ventilate ARDS with severe obesity patients. He is currently the assistant professor in pediatric pulmonology and critical care medicine, Faculty of Medicine of Thammasat University in Thailand. And his focus has been ARDS, septic shock, and dengue shock, COVID-19, lactic acidosis, hyperkalemia, asthma, bronchiolitis. So could you start your lecture, Dr. Sutrong?
Thank you, Dr. Satoshi, for introducing me. First of all, I have to thank the organizing committee for inviting me here today. I have no conflict of interest to discuss today. Today I'm talking about the physiology of obesity in terms of respiratory system. And the second part, I will talk about how I manage the ventilator in the patient with ARDS who is severe obese. And I have two cases to show you about. The first one is the patient with hypercapnia, PCO2 more than 150. And the second case is the patient with refractory hypoxemia with PF ratio lower than 50. That I will share with you how can I manage this patient. Actually, there is a lot of changes in the terms of physiology in the patient with severe obesity, but due to the limited of time, I have to focus the two most important things that change most in the patient with severe obesity. The first one is volume, and the second part is the pressure. Look at the volume first. If we are facing with a patient with a severe obesity who is BMI over 40, and if we see at the functional residual capacity or the volume at the expiratory phase of the lung volume was decreases up to 1/3 of the patient. So this patient need a higher PEEP to recruit their FRC to close to normal FRC. And the second volume is the vital capacity, and the total lung capacity was decreased a little bit, of only about 15%. And since the FEV1 and FVC, FEV1 and FVC decreased proportionally, so the FEV1 by FVC ratio remains normal in the patient with severe obesity. So the first thing that we need a higher PEEP to recruit the FRC of this patient to become close to normal FRC. And the second part that changed in the patient with severe obesity is the pressure. Since the patient with the truncal obesity, they have a lot of adipose tissue that we call the visceral fat inside the abdomen, and it's caused the higher pressure we call as abdominal hypertension. And as well as in the pleural pressure, there has a lot of adipose tissue there. So there is a high interpleural pressure, like compress the lung to harder to expand like a non-obese patient. It's like the patient with obesity has a chest wall stiffness or low chest wall compliance. So they need a higher pressure to inflate the lung of the patient with severe obesity as well, not only higher PEEP, but also higher driving pressure as well. So I have 5 elements to manage the patient with the severe ARDS. The first thing is the prone position, the second is recruitment maneuver, and the PEEP titration, and driving pressure. What is the difference between the obese and non-obese patient with ARDS? And lastly, I will talk a little bit about tidal volume in the patient with severe obesity as well. As we know, the prone position is good for everyone with moderate to severe ARDS who the PF ratio is lower than 150. It's not only improvement of the PF ratio or oxygenation, it also has a benefit in terms of survival. If we use the prone position in the patient with the PF ratio lower than 150, the mortality will be decreased by the half. But how about the prone position in the patient with severe obesity? If we look at this guy who is a severe obesity guy, if we use the prone position, the prone position can recruit the outline that is collapsed, particularly in the dependent part in the dorsal lung region well. And I think the most important thing of the prone position is, if we use the prone position, it can minimize the ventilatory inequality. So it prevents the valvular trauma in the anterior part, and it prevents arterial trauma in the dependent part as well. And it results in improvement of PF ratio on oxygenation, and it also improvement of survival as well. And what is the difference in terms of prone position in obese and non-obese patients? If we look at this study, the baseline PF ratio prior to the prone position is about 115. Okay. And if we compare between the obese patient and non-obese patient, after prone position was applied, in the obese group, the PF ratio is much higher than the patient who is not obese. It's a difference. So please do not hesitate to use prone position in the obese patients. And in terms of survival, in the obese patient, if we use the prone position, the survival is better, not only in terms of oxygenation, but also the survival of the obese patient. If we use the prone position in this group of patients, the survival is markedly increased compared to a non-obese patient. Why? What is the difference between the patient with the obesity or non-obese? That the clue is the intra-abdominal pressure. If I look at the figure B, if we put the obese position in the supine position, they also have the abdominal pressure hypertension, and it decreased the lung or chest wall compliance. So we had to ventilate this group of patients in supine position. But if we turn the patient into the prone position, lovely. If we just flip the patient to the prone position, the abdominal pressure is still high. So it might not be good if we just flip the patient like that. We should do the next thing. We have to put some pillow or towel in the chest and in the thigh or pelvis as well to release the pressure in the abdomen to compress with the bed. And it reduces the abdominal pressure not to 4 times higher than non-obese, but about only 2 times. So it decreased. And if we lay the patient in prone position as long as we can, the intra-abdominal pressure is going down as well as the interpleural pressure as well. So we can ventilate this obese patient in the prone position more easily. And the point is, if we use prone position too short, it cannot save the patient life. We have to use the enough longer period of time, more than 12 to 16 hours a day, in terms to decrease mortality in the patient with severe ARDS. But I think everyone faces this problem as like as me. If we put the patient on the prone position, the PF ratio is going down. But if we put the patient back to the supine position, the PF ratio usually goes down. And how can I figure this problem? I and my nursing team usually use this protocol. This protocol is called as extended prone position. I and my nursing staff at the PICU Thammasat usually put the patient on prone position up to 48 to 72 hours in prone position and doing nursing care in prone position as long as we can. And if we look at in this study, the mean times of prone position in this study is about 70 hours. And if we put in the prone position initially, the lung compliance and PF ratio is going up. And if we put the patient in prone position as long as 70 hours, the PF ratio still going up, and the compliance is going up too. And when we push the patient back to the supine position after that again, the PF ratio is still high, the compliance still high. So I practically use the prone position up to the first 48 hours or maybe some cases to 72 hours. So the prone position is improve oxygenation, it decreases ventilatory inequality, it can improve the survival, and you can use P up the right case. I usually use prone position in the PF ratio lower than 150. I use it as early as possible. I combine it with the low lung volume strategy, and I personally use it as long as about 48 to 72 hours. The second element is recruitment maneuver. Recruitment maneuver is the way to open the alveoli that has been already collapsed. If we look at the picture of the deflated lung, if we want to inflate it or recruit the alveoli that are already collapsed, we usually need a higher pressure to open it. But if it's already open, we can use just an optimal level of PEEP to keep it open. So the pressure that we have to use in terms of the liquid, the collapsed alveoli is approximately 30 to 40 centimeters of water to use. So if we use the recruitment maneuver or we do not use, what is the difference? If we look at this study at the same level of PEEP of approximately 21 centimeters of water, the right two columns is the PEEP titration combined with recruitment maneuver. If you notice, it's approximately the same level of the PEEP 21. But if we combine with the recruitment maneuver, the lung elastance or lung stiffness, which is the lower the better. If we combine PEEP titration with the recruitment maneuver, the elastance of the lung is lower, which is better. And I usually apply lung recruitment maneuver in all severe ARDS case. So the next part is the PEEP titration. Since the patient with severe obesity have a very high intrapleural pressure, if we can measure that pressure by using the esophageal manometer, which represents the pleural pressure, if we use the PEEP lower than the pleural pressure, the lung tends to be collapsed in the expiratory phase, which is not good. But if we set higher PEEP, optimal PEEP level just above behind the interpleural pressure, the alveoli remains open in the expiry phase. And if we compare with the ARDS PEEP table to the PEEP titration by using esophageal pressure, we will see if we use the pressure manometer to titrate PEEP, the pleural pressure is about 19, and if we set the PEEP a bit higher than that level, the result in the lung compliance, if we set the PEEP higher than the pleural pressure, the compliance is better, and the PF ratio is much better as well. So the first modality to titrate PEEP is by using esophageal pressure to monitor pleural pressure and set the PEEP just above that level of the pleural pressure. The second modality to titrate PEEP in the patient with severe obesity is EIT. If we use the EIT technique and we found the cut point between collapse and over distension, and we pick that level of PEEP using with the patient, and if we compare between the ARDS PEEP table and the EIT technique, we will find that if we use the EIT technique and set the PEEP that the level that is crossed over, the compliance is better and PF ratio is much better if we use EIT technique to titrate PEEP in the patient with severe obesity. But unfortunately, my institution do not have both esophageal pressure monitoring and as well as EIT. But what I use in my hospital is I use recruitment manual first, and I perform the decremental PEEP titration after that. And if you compare between what I use in here, I use decremental PEEP titration after recruitment manual. And if we compare with the using of esophageal pressure only without using recruitment manual, you will see if you use the recruitment manual first and then decremental PEEP titration, the elastance is better than using only the esophageal pressure monitoring, and is close to using the recruitment manual and esophageal pressure monitoring. So if your hospital do not have esophageal pressure monitoring, your hospital do not have EIT, you can use recruitment manual with the decremental PEEP titration. It's a good alternative option as well. And if we see the higher PEEP or the lower PEEP, which one is the best? It's different between the non-obese and obese patient with ARDS. In patients with non-obese, the lower PEEPs look like to associated with a better outcome. But on the other hand, as we know that the pleural pressure is higher in the patient with obesity, so if we use the higher PEEP, it's associated with the lower mortality. So in the patient with severe obesity, they usually need a higher level of PEEP. Okay, the driving pressure. I think the driving pressure is a bit confusing topic. But back to the classic study of that we call Delphi study to demonstrate volutrauma. The Delphi study performed this study in the animal and has 3 arms. The first arm is the high pressure, high volume ventilation, and the third arm is high pressure. But they strap the chest of the animal with a belt, so use high pressure without high volume. And they compare between the pulmonary edema or excessive lung water. The result that show that if we use even high pressure, but we limit the overinflation of the lung, the pulmonary edema is much less compared to the high pressure, high volume. And if we look at the patient with severe obesity, they are naturally strapped with the fat, not a belt. So they have a natural belt strapped their chest with the fat. So even we use the higher driving pressure, that not allow patient to be overinflated more easily. And this is what we call that is transpulmonary pressure. That is represent the lung stress or represent the lung volume in the inspiratory phase. So the driving pressure is different between obese and non-obese. If we look at the amateur study, the higher driving pressure is associated with a higher mortality, right? But in the obese patient, it seems that driving pressure do not associated anymore to the higher mortality. So you can use driving pressure as high as they need. Just forgot the magic number of 15 in the severe obesity guys. So the last topic, I will touch a little bit about the tidal volume. As we know that what we call as a baby lung concept, if we perform the CAT scan in the ARDS patient, the remaining well-inflated lung zone is about 1/5 compared to the normal lung in non-ARDS patient. So if we use normal tidal volume in this type of patient, the baby lung zone will be overinflated and volutrauma would be happen there. So we have to use low tidal volume ventilation. But what is the number of tidal volume should be used? If we look at two figures of two ladies, the upper lady has a weight approximately 125, and the second lady has a weight only 27 kilo. And if we perform the CAT scan to measure the lung volume between two ladies, we will find that the lung volume is approximately the same. Even the weight is quite different. So the lung volume is depend on the height and gender, not depends on the weight. So you cannot use the actual body weight to set the tidal volume in the patient with obesity. You use ideal body weight or predicted body weight rather than actual body weight to set tidal volume in this patient with severe obesity. So lastly, I have two cases to share with you. The first one is the 6-year, which has a body weight as high as 60 kilo with a COVID ARDS with severe hypercapnia. And the second one is the 4-year-old, 50 kilo with refractory hypoxemia. So the first one is the COVID-19 ARDS, which I faced is the PCO2 145, and the pH is as low as 7.0. So I used 5 elements that I shared with you earlier to combat with the problem. So I prone position first as soon as possible, and I standing at the head of the patient with my nursing staff and my resident. And the second thing is I use the recruitment maneuver, and then I perform the decremental PEEP titration, and I augmented the driving pressure as high as 25, and then I limit the tidal volume to 6 ml per kilo. And after that, I follow the blood gas. The CO2 is going down from 145 to only 50, and the pH is going up from the 7.0 to the 7.4. And she can discharge safely home, I think, a week after that. And the PF ratio is markedly increased after recruitment maneuver and decremental PEEP titration was performed. And the second case is the COVID-19 ARDS with refractory hypoxemia. This patient on FiO2 100% with the PEEP level of 15, and the driving pressure of PIP is 17 above the PEEP of the 15. And when I saw this patient at the first day of my service at PQ, I said, oh, the oxygen index is sky high, so he is the VV ECMO candidate, right? But at that present time, we are reluctant to use VV ECMO in the COVID-19 because I and my staff and my CVT surgeon are a little bit scaring of to push the COVID-19. This case is about 3 years ago. So that time we are afraid of. So I use the 5 elements to cope with the problem of severe hypoxemia in this case. I use the prone position first. I perform the recruitment maneuver. I perform the decremental PEEP titration. And again, I increase the driving pressure up to 24. So do not affect the driving pressure over the 15 at the magic number of amateur study. You can use as high as you want. And if after I recruited successfully, I can decrease PEEP only 11. So the result will show that PF ratio is increased to 201, and oxygen index is going down from 49 to 13. And he can discharge safely with his mom a week after that. So summary, if you ventilate the ARDS with severe obesity, you should use the prone position as soon as possible. You should use the recruitment manual in every single case of the patient with severe ARDS and severe obesity. And since the blood pressure is pretty high, you usually need to use the higher level of PEEP to prevent the atelectasis in the expiratory phase. And about the modality of PEEP titration, you can use esophageal pressure, you can use EIT, and you can use the decremental PEEP titration after recruitment manual as well. And you can set the driving pressure just as high as you need. Forgot the magic number of 15 anymore. And finally, you should use the lower tidal volume from the ideal body weight or predicted body weight, not the actual body weight in the patient with severe obesity. Thank you.
Thank you very much, Dr. Sutrong, with sharing the physiological approach to the obese patient in ventilation, mechanical ventilation. As you need to remember that there's in the systemic elastance, systemic respiratory elastance, there's one component is lung elastance, and the other component is the chest wall elastance. So if you want to expand the lung, you need to apply the higher pressure in order to expand the lung as well as expand the chest wall and maintain the higher PEEP in order to maintain the lung. So this is a key message. Thank you very much for the very nice presentation. Any questions from our audience? Thank you very much. Sure. Dr. Nikan.
Hello. Thank you, Doctor, for the nice presentation. My name is Nikan, and I come from Jakarta, Indonesia. I have two questions. First one, how high PEEP can you given in your experience in obese patients, especially in lung recruitment maneuver? And was there any complication regarding those high PEEP? Because in Jakarta, we've once giving like 35. Okay, and then the second question, is there any role for doing recruitment maneuver every day in ARDS patient, especially in obese patient? Thank you.
Thank you for the nice question. The first question is how I perform the PEEP, decremental PEEP titration, and how high level of that PEEP level. Honestly with you, I will start with the recruitment manual pressure approximately 30 to 40. So I use the PEEP about 15 to 20 first, and the PIP, I choose the 15 or 20 above that PEEP of level. So the total pressure is approximately 30 to 40 centimeter of water. And I titrate PEEP down about 1 or 2 centimeter every 2 minutes. And I look after that which the optimal PEEP level will be, and I recruitment it again, and after that I turn the level to the optimal PEEP level lastly. So personally, I use the PEEP at the first time approximately 15 to 20, and the PIP 15 to 20 above that PEEP level. And the second question is, I personally use the prone position for the first 48 to 72 hours, and I use the inline suction. So it's might necessary to perform recruitment manual again and again. But if we have something that we have to open suction, such as a large amount of secretion, I usually perform recruitment manual after the recruitment events like disconnection of the tube system or the suctioning. Thank you.
Okay.
Thank you. My name is Bayu from Indonesia. Thank you very much for such a nice case presentation. My question in giving or applying such a high number of PEEP and delta pressure to your patients, do you find any hemodynamically instability? If such things happen, do you have any advice for us? Thank you.
Thank you. As we know that if we use too high intrathoracic pressure, it will make the decrease in venous return and the result in the hypotension as well. But if we look at the study from the higher and the lower PEEP trial, if we use just right PEEP, the PEEP can recruit the alveoli. And when the alveoli is recruited, the pulmonary vascular resistance is decreased. So the PVR was going down. It means that the blood flow can go to the lung more easily and return to the left side of the lung more easily. So if you use just the right PEEP, not too high, not too low, it's correlated with the lowest, the pulmonary vascular resistance, and it seems not to make any a negative effect on the cardiac output. I think if you face with a patient with a severe lung diseases, you can use as high as is needed. And if you use the right number of the PEEP, the blood pressure or even the cardiac output is usually better if we compare to the too low level of the PEEP. Thank you. I personally do not face with the patient with the hypotension after recruitment maneuver or decremental PEEP toleration often.
Thank you very much. Very nice talk, Dr. Sutrong. By closing the session, I think Thai Society will present the gratitude to the international speakers. Am I right?